said, the first part will be broadcast through webinar, and we'll send you the internet link afterwards, so you could listen to the presentation afterwards if you missed it. So pass that information on to your colleagues. If you have any questions that I'm not able to answer, or if you have questions after the presentation, so please contact me either through our CREGÉS beautiful website that we've translated, my Facebook account to get my coordinates, and you could send your question and I'll redirect them to the panelists that could answer the question. So why a presentation on April 16? Well, today is the Canadian Advanced Care Planning Day. Every April 16 there's a major event to promote Advance Directive in Canada and also in the United States. So we decided, well, let's put something together and invite some of our colleagues to share the presentation. So today we'll have the honor and pleasure of having Tamara Sussman, professor at McGill at the School of Social Work, Kevin Hayes, ethicist at our CIUSSS, West Central Montreal, and Dr. Karanofsky at the end of the table, professor at McGill also, and also director at the GMF-U Herzl clinic at the Jewish General. So it's family group medicine. So today we'll present the Advance Directive, which was set by the Bill 2, the Law 2 on end-of-life care. Mrs. Sussman will present a research project and some results about using some tools to initiate conversation with residents in a long-term care setting. Kevin Hayes will discuss the level of care or goal of care established by frontline workers and frontline professionals, with families, care, patients, and residents. And finally, we'll discuss at the end how to approach palliative care with residents and caregivers in long-term care setting. So if we look at Bill 2, and it was put in place in 2015, there's a new aspect which allows individuals to write their wishes in terms of care they want at the end of life. So this Advance Directive hasn't been publicized very well in Quebec, in Montreal, or across Quebec, and there's been a little campaign of information, but not very much. So that's why there's only a few thousand people who registered to that computer rights registry. So it helps individuals to decide what type of care they want at the end of life, and I'll dive right into it. So basically, people can consent either to get cardiopulmonary resuscitation, what we call for CPR, be on assisted artificial feeding or forced artificial hydration. So those are the types of care have forced or artificial feeding or forced artificial hydration. So those are the types of care you can consent while you're at, in the event that you could become inactive. In any case, if you're at, of course, or if you're able to consent to the care, the treating team will have to have the legal obligation to consult you and ask what type of care. So it's a very specific life-sustaining treatment that's really at end of life, and it applies only if you're at end of life situation, comatose, or with advanced dementia, or unable to respond or consent to the care. So those are the specific clinical situations where the Advanced Medical Directive applies. How to order them? Well, you can call the RAMQ, which is the Régie d'assurance maladie du Québec, and or you can do it by phone with your medical card. Give your medical card, and they mail it to you. You read it carefully, sign it, and have 2 witnesses sign it and mail it back. So it can be computerized and made accessible for all physicians in Quebec. Of course, you have to be 18 enough to consent to the care, or you could also order it online on that website. And with your Click Secure code, you could download the form and print it, sign it, and send it back to the RAMQ by mail, so it could be scanned and put on the computerized registry. Tamara.
Great.
Great.
So I'm going to be talking to you today about a series of pamphlets that myself and my team, and Pamphlets included in this, developed for 5 illness conditions that are rather prevalent in long-term care. And the reason we developed them is because we know that engaging people early on around end-of-life conversations really help prepare them for making in-the-moment decisions at end of life. Yet despite the fact that we know that, these conversations often don't happen until final days of life. And even in long-term care, where people are already coming in at quite advanced stages, we're still finding that the conversations often people are scurrying at the end. So some of the challenges specific to long-term care, there's already a stigma associated with long-term care. So when someone comes in the door, people are anxious to be talking about death and deterioration when they're trying to also promote the idea that there is quality of life in long-term care. So that's one challenge. And there are also really limited tools specific for the kind of conditions that are prevalent in long-term care. A lot of the stuff in the area of palliative care comes out of cancer care and oncology, but these are not the predominant cases in long-term care. So our team, with a lot of consultation from people in the long-term care sector, developed 5 illness condition pamphlets, and we've got examples of them at the back if you're interested. The aim was really to educate residents and families around trajectories for particular conditions, and also the hope to activate more of these conversations earlier on. So we have pamphlets for lung disease, heart failure, kidney failure, dementia, and a sort of broad-based term used a lot in family medicine, frailty, which is a mix of a lot of things. And we chose those particular conditions because, again, working and consulting in long-term care, we were told these are the ones that are most prevalent and the ones we really want help with. So if you look at the pamphlets, you know, they include a little bit of what might I expect at sort of a more advanced stage of X condition, and it gives some sort of signs and symptoms. And the prompts are, what kind of things might I ask? What kind of decisions might I need to make? So it's really about giving people information to then hopefully engage in conversations either with one another or with staff in long-term care. So what I'm going to present to you today, we wanted to see if these things were used, if they were acceptable, if they broke down some of the barriers that I mentioned, and then to explore also, you know, how they might have been used by staff. So this study was done in Ontario in 4 long-term care homes, and we really didn't prescribe a particular kind of distribution. We had the pamphlets on sort of display cases in long-term care, and staff were welcome if they felt comfortable distributing them as they saw fit. What some staff did is in those annual care conference that staff sometimes have, if it seemed fitting, they might present a family member or a resident with a pamphlet at that time. We surveyed 57 residents and families. We conducted 7 focus groups with another 56 residents and families, so we have, you know, quite a bit of their representation, and we also did surveys with 178 staff persons to get their perceptions of the information. So a total of 348 pamphlets were distributed between the time period that we did the study, and the ones that seemed to be the most commonly used by the residents were dementia, heart failure, and the frailty pamphlets. And the staff, dementia and heart failure, those seem to be the ones that people wanted and needed the most. From the residents and families, people felt that the information was clear, it was relevant, and I think importantly for staff, only a small percentage felt that it was distressing to get this information. This is often a fear of staff. People also felt a lot more informed and increased comfort in terms of beginning these kinds of conversations with families more so than with staff a bit. It kind of primed them to at least have a conversation with their family members. So one of the things that we learned interestingly from the focus groups were that because we had put the display boards in one part of the long-term care home, the residents felt they weren't that accessible to them, and they were asking for these pamphlets to be displayed in all the nursing stations so that they too could find them a lot more easily and read them, those who were capable. People really valued the illness-specific information that was in the pamphlets. One family member said, when I started reading, I went, oh my gosh, this is exactly him right now. All of a sudden, you don't feel so helpless. So the information really armed them with a sense of power. One of the things that came up, maybe no surprise to many clinicians, is that The family said, I really wanted this information, but I'm worried about what my family member, how my family member would take it. The resident said, oh, I love this information, but my family would be so distressed if they learned this. So they were so concerned about burdening the other that they needed someone to help them come together. So the pamphlets maybe served as a primer, but not necessarily to then activate the conversation between the two. The staff really also found the information usable and had some comfort sharing the pamphlets or had plans to share the pamphlets. Interestingly, even few staff felt that the pamphlets could be harmful to residents and families. We thought we'd get higher endorsement of that. But what we found here that was really interesting was when it came to, I am the appropriate person to share the pamphlets, that was a lot lower. Far fewer people endorse that because no one knows who's allowed to have these conversations. And, you know, medical directives, which are very much about making medical decisions in advance, require someone with medical background to have these conversations with. But when we're talking more broadly about your values and interests around your future care, this is something that a lot of practitioners can engage with. And my team are very strong advocates of supporting préposés to support these conversations as well, because they're the ones who are there at 12 o'clock at night when a resident is distressed and looking to have a preliminary conversation. So for sure what we found, which maybe is no surprise but something to work on, is that when it came to asking sort of regulated staff, which would be nurses, social workers, they had significantly more comfort distributing the information than more of the support staff. So what that told us, I think I'll skip that too, sorry. What that told us was that the staff needed some strategizing around how and when and who might give the pamphlets and what happens next if somebody wants to ask a question. I think that's what they were worried about. What we also found was a strong amount of staff have actually used the pamphlets for self-education. That even though they thought it was very useful for the pamphlets, they also appreciated having a little bit of this information themselves that they then could use to ask another staff person who might have more background, more questions, and they felt that they were understanding the symptomatology a little bit further. So in conclusion, I think I mentioned this, that it seems that these are promising in terms of information sharing, but around activation of conversations, I think we need training for staff to talk about different roles, and certainly it seems that some support for families and residents to have that conversation are warranted. And for all of you to know that all of these pamphlets are publicly available on the Canadian Hospice Palliative Care website. We've got them specific for Quebec in English and French, and we have them for about 5 other provinces as well now. So they're starting to get used.
Thank you.
And I should acknowledge my
Credits.
Yes, credits. Okay,
Kevin.
So, thank you, Patrick, for inviting me. My name is Kevin Hayes, and I work in clinical ethics in our CIUSSS Southwest. And I'm going to provide a brief presentation of the subject of goals of care, or previously known as levels of intervention. It's something that I'm very involved in from an ethics perspective, because there are often conflicts between what the healthcare team proposes as a goal of care and what the family or the substitute decision maker might want as goals of care. So I want to explain to you a little bit of what it is. We have a policy, it's been in existence for many years, to identify levels of intervention, the goals of care that that patient or resident or a client might want for themselves as they engage in the healthcare process. The policy is now in a revision stage following the implementation by this organization called CIUSSS with the government about standardizing goals of care across Quebec, so that we will have one form that everyone uses, whether you're at the Jewish or you're at another hospital, and it'll be a very standardized kind of approach. So that policy is on its way. It's really a Quebec-wide initiative to ensure that we're all speaking the same language when it comes to goals of care. So the guiding principles are, first of all, to adhere to our mission, vision, and values as an organization. We have a perspective about how we think healthcare needs to be done, and the use of the goals of care, the implementation of goals of care should be linked to the mission and values of what this organization is about and what the professionals who offer our service believe in. It's a vital partnership with patients, with residents, with clients, substitute decision makers, and families. They would all be included in the discussion about goals of care. That the organization respects human dignity by providing care that is clinically and ethically appropriate through goals of care conversations. We seek to understand patient values regarding care choices. So this is about a conversation when you are particularly at the beginning of a healthcare scenario, whether you're being admitted into the hospital or you're a new resident in a long-term care setting. What are your goals of care as you enter, as you are admitted into the hospital or into your long-term care center or even in rehab? What kind of interventions would you want the healthcare team to do for you in particular situations? So they take place early on in the course of care. They explore patients' wishes and goals for care framed within the therapeutic options that the treating physician has determined appropriate for one's condition. So physician, particularly a physician, is the one who should be conducting this conversation, though with a great deal of support from everyone else, the nurses, OT, PT, whoever else might be involved in ensuring that this conversation takes place. And an advance directive, if completed and made available, may inform conversations regarding goals of care, because somebody may have decided in advance of dementia or other circumstances where they can no longer make those decisions. An advance care directive might have been the document that identifies, while I was competent, what I might want for myself when I'm no longer competent. And so that is a very important document that we take into consideration. So these goals of care conversations are done with the patient or the resident. If the patient lacks capacity to make specific decisions, then it can be done with the patient's representative, who is the substitute decision maker. So family members often, I would say, identify somebody or numerous people to be the ones to make decisions for them in the event that they can't make them for themselves, husband, wife, children, friend, neighbor, people that they trust, who they're close to. So we would have those goals of care conversations with substitutes in the event that we cannot have it with the actual patient. So what's included in that conversation, because it's a pretty important one: patient status, prognosis, and anticipated outcomes, patient's values, hopes, and wishes in the event that a crisis situation occurred, heart attack, or code, as they call it in the hospital or even in long-term care. What would the patient want done for themselves in the event that that occurred? The role of life support interventions, risks and benefits. So we talk about the risks of a life support intervention and the benefit of a life support intervention, and allow the patient, the resident, or the substitute to make decisions with that information. We talk about comfort measures, because there are circumstances where the level of the goal of care might be comfort care and palliative care, considering the status of the patient. And so that might be a conversation as part of the goals of care. Medical recommendations, what the team might be proposing as the best approach for that particular patient or resident, and an offer to involve other resources to assist, meaning maybe social services need to be involved, psychiatry, occupational physiotherapy, other people who can provide the best kind of professional assistance to the patient or the family. We have a tool that we use to facilitate communication between healthcare professionals, the team, and the patients, residents, and substitute decision makers. And we identify those levels or those goals of care. They're all very important. Every single goal, every level is important. There are 4 newly identified goals of care in the new policy that is being introduced in our CIUSSS. Before it was level 1, 2, 2B, 3, and 4. Now we have goal A, B, C, and D. and they're on your PowerPoint. So goal A, prolonged life with all necessary care. That could be a decision, option, a choice made by a patient or resident. Prolonged life with some limitations to care. Ensure comfort as priority over prolonging life, and then ensuring comfort without prolonging life. So these would be the choices that patients, residents, and substitute decision makers might have. They are part and parcel of a very, very important conversation, and we engage as much as possible in every single situation of residents and patients who are admitted to hospital or in long-term care or in rehab to make these kind of decisions. And I know they're very hard decisions to make, but they are certainly extremely beneficial. When we talk about goals of care, we often also have to make mention of capacity to consent, ability to understand and appreciate one's condition, the purpose of a treatment, and other options, as well as the consequences of one choice over another. So if you have capacity to consent and you can understand all this information, you as the patient and you as a resident can engage in that conversation and make your own decisions. A substitute decision maker is someone, as I mentioned before, who has the authority to consent on your behalf. That might be someone who is identified by you to make those kind of decisions, and these decisions always include goals of care. The importance of the Advance Directive. So each individual makes his own decision when and if the time comes. So we support the idea that Advance Directives is an important document. I know in Quebec, there's this whole initiative to have an online resource where people can actually save their Advance Directives, and we can easily access those, because sometimes when you're coming to the hospital, the document might not be attached to you or with you. And then in that case, it would be hard for a physician or anyone in the team to actually know what your decisions might have been prior to this emergency situation. So we support the importance of Advance Directive, which could form part of the decision making in the goals of care. So I hope that's clear, and I can tell you in our CIUSSS at some point it will be something we are sharing very soon in 2019 with all of our teams. It's going to be a major project. Thank you.
Thank you, Kevin. I need therapy. I'll just ask a question of the group. Anybody here is a family member? Are we all professionals in the staff? Okay. So I'm a family doctor. I've worked at elder care for 12 years now. I've worked for 3 years in long-term care in Ottawa. I work on the wards in the hospital. I work in long-term care, and so I've been through this for quite a while with a number of people. I showed up to Jewish Elder Care September 1st, 2007, and I inherited 40 patients. The average length of stay in long-term care for all of our patients is 2 to 3 years. The highest risk of death is in the first 3 months. That's when the highest risk for our patients is chronic. You don't make it into long-term care because you're healthy. You make it here because you've had a whole bunch of comorbidities and lots of problems. And the vast majority of the patients that come in here aren't able to make these decisions for themselves. I would say 80 to 90% of patients either are declared inept or are unable to make the end-of-life care decision. So it is a substitute decision maker that is often asked to make these decisions. I will say this, my personal preference is that it's a team effort. My experience has been sometimes the nurses and the social workers know the patients and their families far better than I will, and they're better to initiate the conversation. From a legislative point of view, I think the bottom line is going to require a physician signature at the bottom of the page, but I still think the larger team is actually probably better equipped to make the discussion. The policy for the CIUSSS is going to be that you have 7 days for admission to long-term care for somebody to sign that form. In the hospital, it should be 24 hours from admission. In reality, it'll be, the target will be a week. But my personal policy here, when I was at elder care, is within the first 7 days, I at least try to have that conversation with the substitute decision maker. And it's not an easy discussion at first because it's a shock. Getting into long-term care is traumatic. I'll be honest, my grandmother was a resident of Maimonides, and she passed away on the second floor here a couple of years ago. And for us as a family, the decision to come here was pretty easy because she needed the care. But we appreciated that the respect for what the Advance Directives were going to be. And that was one of the main argued for her. And she was only here for a couple of months because we knew she wasn't doing well. But at least her directive, what she would want, was what was expected of her. And the way I approach advanced directives in long-term care is I tell the substitute decision maker, your job as a substitute decision maker is not to decide what you want for your parent or your loved one. Your job is to say, this is what they would have wanted for themselves. And say, if you can look in the mirror and say, this is what they would have chosen, that's probably the right decision. And I like the term goals of care because they say, where do you want me to go? What direction do you want me to go? Do you want me to go to the left? Do you want me to go to the middle? Do you want me to go to the right? And if you tell me I'm supposed to go to the right, and then you start pushing me to the left, that's the wrong answer. And so I say, set the goal of care. Tell me what you want. Tell me what this person would have wanted for themselves. And then I can say, okay, here are your treatment options. And I always tell them there's never no choices. There's always choices. It's just a matter of what is our goal. And so I never tell people there's no more options left. There's no choices left. There's always something I can do. And it's just a matter of what is our goal here. And as soon as you've established that, that's kind of the way I work with families and patients. And it is a process. Sometimes people are not there on the first day. I have one gentleman in elder care who, it took me probably about 1.5 years, 2 years to get his daughter ready for him to pass. And about 3-4 months before he passed away, we were able to have this discussion so that way she would be comfortable with that end of life. And so it isn't necessarily a drop and you have to figure this all out in one moment. But when someone does change, when their status does change, it is a time where we have to have that discussion again. And it can be initiated by any member of the team, and then the discussion. And the more consistent we are with the language, I think the better. And there's one thing I would always say, please don't ever tell somebody there's no choices, there's no options. Because that puts people's backs up against the wall. And I think being open to directives and what's the goal, that's kind of difficult.
Thank you very much. Is there any questions from the webinar or the audience? And from the audience, if you can use the microphone in the middle aisle so people can hear you either through the webinar. So the mic is open for the audience if they have any questions or reactions about the presentation.
Yeah, because otherwise it won't be on the
webinar.
Just forward.
I'm a social worker. I tend to give out the living will that comes from the GMF-U website regularly. Is that something I should be avoiding, and when those documents come out, should be giving that instead? Because on a regular basis, I give it out the living will.
So the question is, should the living will, either from the Jewish General or from other establishment, should be used in our daily practice?
I would still use it. It's a very interesting document created by Michael Dworkin, who's one of my colleagues at Herzl. The idea is not that it's actually a legal document that you have to follow. The biggest challenge we have is that people don't often talk about this, and people don't write it down. And so having those types of things written down by somebody in their own pen is actually kind of interesting for somebody later when they're faced with, I never talked about it with my mom or dad, but then they pull this out from somewhere and they say, but this is what they wrote for themselves. Most families struggle with the fact that they say, I never talked about this with my mom and dad. And I find it hard to believe that nobody has any inkling. They don't want to talk about it. It's kind of a taboo subject. But people will come up with substitute measures. They'll say, well, what do they think of people with dementia? How would they feel? Were they comfortable going to visit their parents when they were ill? So there usually can get some sign. So the Advance Directive Living Will is a discussion point. And so as people go through their lives, I think it's important to talk about it. One of the things I tell all the families when they come into elder care is I say, you see how hard this discussion is that I'm having with you about your parents. Have you talked to your kids? Have you talked to your husband or spouse about what you would want for yourself? And I would say a lot of them say, okay, I will, and probably about half of it. Maybe.
Kevin?
So in ethics, we talk a lot about autonomy, right? Self-determination, people making their own choices for themselves. Big example of the Advance Directive, it really is an ultimate example of self-determination and making your own choice. The burden of this very hard choice is on your own shoulders versus on somebody else. It's not very hard for spouse, children to have to make these difficult decisions. But if you made it yourself at a time when you could have made it, and you really alleviated a lot of responsibility, taking it off the other people's shoulders, and you made your own choice, which is good for you. And so I know in Quebec there's a movement now with all the documentation that's coming out to do more and more of that, for people to be autonomous and to have self-determination, make their own choices, and that family members at the end are just respecting the choices you wanted for yourself, which is great. That's why I would definitely promote sharing that kind of a document. And if people want to use it, they do. If they don't, they don't. But it's certainly important.
So the online form is irrevocable by anybody other than yourself. So your substitute decision maker cannot change it. So you can't say, oh, they would have changed their mind. It doesn't matter. That form in the Bill 2, when they came into law, says that is your signature. So if you become inactive, that is your advance directive for the rest of your life.
Unless you go back there and change.
No, if you're inactive.
Oh, if you're inactive.
You cannot, your substitution maker cannot change. Whereas the living will, somebody could.
So if there's a contradiction or any discrepancy between the living will, which might be submitted, let's say, to the hospital, and the life.
The one online is the one on, the online one that's on the government is
That's
firm and
the-
final.
To pass the one that's been established in the living will. So the question was the living will versus advance directive, medical directive. Which one will proceed? It's the one, the advanced medical directive that will surpass the living will, or any other document that is still phototyped here.
So just, I like to say that there's something called advanced care planning, which is thinking about, reflecting, communicating what you might want in future should things happen. And many of those tools fall into that category. There's at least 35 that you can find online that get people, they're just prompters. And then there's the official legal documentation, and that's what I think you're enforcing. The advanced medical directive, that is a decision made in advance and documented that we are expected to honor when the moment comes. And that's the only thing that I think exists in that regard is these advanced medical directives, and I believe they need to be notarized. There's some process.
No, you have two adult signatures, and you have to send it back to the government.
Right, you send it back.
It could be done with a notary if you want to have it done by the notary. The notary will forward to the registry, but this free document is accessible for everybody in Quebec to have it done, and witnesses sign it and send it back so it gets scanned. I would recommend that you keep a copy and that you give to your family doctor, your treating team, so
For people to continue to look at that, maybe even every few years if you've written one, to make sure that that's still what you want. Because once you become inactive, about the guidance, I said you can't change it, but you can change it frequently, potentially, before.
Julie.
There's a question from a participant who living on that. Question is, how can we put this policy in practice for clients who have intellectual deficiency and mental issues, especially when the client and family are opposing views or a relationship that is not so harmonious?
So the question, how can we address the views and values of the person who has an individual challenge versus the family's wishes in terms of care planning? Paraphrasing.
So the issue, capacity to consent, is an important issue, particularly in that kind of example. And I've certainly been involved in situations where somebody wouldn't have capacity to consent, and what they want differs from what their family members or even substitute decision makers might decide, which now creates this conflict. And it's not an easy situation to be resolved. In ethics, we do this thing called bioethics mediation. So we try and mediate an understanding between the client or the patient versus the family members involving the healthcare team as well to be able to come to some kind of a understanding and a consensus afterwards that is in the best interest of the client. I can't give you an exact answer. I'm saying I'm hoping that that process will be able to help create a response that will satisfy the client, but a significant effort is made to ensure that there is discussion and conversation so that the client's wishes, even if they do not have capacity consent, we listen, we hear, we're engaged, we're involved. It's not minimized or ignored. It's nonetheless held with a great deal of value to be able to ensure that we come up with a conclusion. But it is definitely a complicated scenario.
Can you hear me, or should I come first?
So just one intervention before, and then we'll take your question.
Just sort of add two things, not that it results in for now, but there is a lot of debate around shared models of decision making, around moving away from this, extreme, you have capacity or you don't, and it's static and it's fixed. And I think where our wiggle room, it's what Kevin is saying, is really just being the voice of that individual to the best of our capacities and reminding family members that their obligation as decision makers is not to do what they think is best, it's to do what they think their family member wants. And sometimes that can move a conversation a little bit.
I can just add that's absolutely super important information. We don't do what we want because we think it's good for us as substitutes and family members. That's why these conversations are so vitally important. What does the patient want? What did they want for 20 years? What did the resident want before she came into long-term care? And is family imposing something that they think they want, which is not what the resident might have wanted before they became inapt or lost their capacity to consent? So that's important, and that's a question we ask. I hear what you want as family, but what did this resident always want? Was there a conversation? Unfortunately, it wasn't written down, but do you remember those kind of conversations at the dinner table about what they might have wanted over many years? And even at that time, they might be expressing something that we need to hear as important.
I've been called to court to testify on behalf of the patient what they would have wanted for themselves. And so the court actually is a kind of a last resort, if need be. But it happened, and I was called even by the team of the hospital for a patient that I'd known for 10 years who couldn't make the decision about a feeding tube or not. And I went up and it was consistent with the value that I knew him to put it in. It was an easy 3-minute conversation, but getting people who knew them over time can help make the decisions easier. So having these conversations is ongoing, I think, is important.
There was this location in my mind, and my late brother was at the Jewish General. He married a vegetarian. He was involved in a huge, as you know, huge issue on this. What I find most difficult here is that decisions are made for me that are against what I want now before I'm anywhere near the last days. And I'll just give you a quick example. And that's why I like this idea that we work with each other. A TRP was not a physiotherapist, walks in the room. I sit up and he says, "You're not sitting up properly. It's dangerous for you to sit up." Walks to the nursing station and says, "Thou shalt not sit up anymore." Well, I haven't been sitting up like this for 9 years. I had neurosurgery, and I fight to sit up, and I'm sitting up. So, the battles go on continuously to be able to care for ourselves the way we want to be cared for. And I think, God help me when I get to those days when I'm still fighting to continue, when they shut the door on me completely here. So your discussion is very important. And I've seen often with my own relatives terrible battles of what goes on. And when I sat in the courtroom after my late brother passed away and listened to what went on there with the debate of what should have happened and didn't happen, it's very hard. We have to watch these patients from day one when we get them. Who are they? What are their wishes? And how can we help them to continue their life as close to normal as it was and not shut it down? So that's my only statement. I have to go back upstairs before they shoot me down my life.
No, Thank you very much.
Thank you for your testimony. Other questions? Feedback?
People under public career, what's the course of decision making?
So that's a good, I like that question. What is the process for career? Because I had to do this. So Dan, who was speaking, was my head nurse for a couple of months. I've been trying to steal him back. We will negotiate afterwards. I found this out from working at elder care. So when someone gets admitted, there actually is a form off the public curator's office where you print it and you ask the public curator to make a decision. And as a physician, I have to complete the reasons why I want it and what my recommendations are. And then the curator has actually a specific, you can fax it back to them, and within 24 hours, they will fax you back with the decision of the curator to say which way that they will accept that. It's exceptionally rare that they will go against a physician's recommendation, especially in the long-term care setting, given the fact that most people are fairly ill at that stage. But ideally, you won't make that decision without trying to do your homework to find out what the patient would have wanted. But it is, the process is a form, and it has to be a physician faxed to them. In an emergency, there's always a 24-hour curator, but it's historically not the easiest thing to access.
Other questions, comments for the panel?
Just to go on that topic, my understanding is that despite them doing that, they should still be consulted, so should they not do the whole concept on this one? So would they not still need, in the absence of having that documentation, still to check in to see if there's an understanding, you know, the whole Nova Scotia scale, all of that, despite being in that, so.
So the question was, should we go back to the patient and ask them what they would want, even if they've been declared inept? Absolutely. I think it's actually one of those things that consent is in the moment. And to me, even if it's gone to court and you've promulgated a mandate, if somebody's absolutely physically refusing to take a treatment, you're actually not allowed to give it to them. And so it's in the moment, can that person make that one decision? And competency is so complicated. Can you make the decision now? Well, that might change in 15 minutes, and your understanding of it might be complicated. So you might not be able to do math, do your banking, and to go punch in your ATM code. But you might still have enough old memory to say, okay, I wouldn't want a tube stuck here. And so, or this really hurts me now, stop doing that to me. So there's different levels of competences, and you're supposed to inform the patient. And on the form for inaptitude, when you go to the curator or to court, you actually have, there's a box that says, what date did the patient informed of this decision? And so you always still go back to the patient, and the person that we work for is the person in the bed. And as long as I'm respecting that person, I think that's kind of the goal. When I'm doing something for a family member more than I'm doing for the patient, that's where it starts hurting me. And I try to gently tell that to the family that I'm not doing this because I want to hurt you. I'm doing this because my first responsibility is to your loved one. And my job is to advocate for them, so is yours. But we have to come up with something that reflects what they would want for themselves. And if they're fighting me to give them an intravenous, I'd say, do you really think that they would want me to be making them scream and yell? But you have to still go back to patient.
Sure. So we have 5-10 minutes. Any last questions, comments from the audience?
Well, a lot of our biggest challenges here, specifically at minorities, I know we discussed this with Dr. Karanofsky on multiple occasions in the past, and the form that we see in the initial case is different from our Advance Directive form, is who's responsible to do it. And we clarified with official policies. Our challenge is our doctors are not here present at the building often. Most of them come once per week for 2 hours. And many of them count on nursing staff approaching the families on admission, discussing the levels, explaining, and then some of the nurses even sit with the families and they sign the form with them, and then the doctor comes 2 weeks later, and some of the doctors call the family to validate, others just complete the form. So So as long as I remember when we had the discussion, it's only the physician who has the legal responsibility
It's all
to address
changing.
the issue.
But it's all changing. So this new form that's coming out, the CIUSSS is writing the policy now on how it will be rolled out everywhere in the CIUSSS. But essentially, it's not going to prevent anybody else from having the discussion, but it will require the discussion to require the physician's signature at the bottom of the page. It won't require a nurse to sign it, and it will not require a patient to sign it, although there is a place where the patient or the substitute decision maker can sign it. As well, the policy in the CMDP, which is what I sit on, is 7 days after admission, it must be done. It won't be 100% done. No policy is ever 100% followed, but that will be the policy, and will be the responsibility of the physicians to do it. And that's okay. And if the physician group needs a little bit of pushing, that's okay as well. I think having this discussion with the team isn't appropriate. I think, I'm hoping as part of the policy, the entire allied health and medical team will be encouraged to have these discussions with patients. And it won't be limited to the doctor. You must be the only one that has the discussion. So my mom needs elder care, father, that all of these centers might actually start doing more where other members start the discussion. It's just at the end, who's going to sign the form will be the physician.
So if I could just add to that, in fact, we did identify in the policy that it is a team conversation. At the end, the physician does have to participate in the finalizing of that conversation, I would say for the signature purpose, but really the team can converse. They know the resident or the patient very well. They're sharing information with the physician, but yes, the physician does have to participate at some point. But the team has a role to play, and we identified that in the policy.
Because it doesn't only touch the initial completing of the Advance Directives. Further, when the patient's condition changes and deteriorates, especially when it comes to end-of-life discussions, it requires more frequent talking and explaining and exploring options, what we can do here, what we cannot do here, and this is always very challenging when we don't have the right person to explain this to the families, and the families are searching information from the rest of the team.
I'm a big fan of not absolving anybody of their responsibility, and I do it, like I can only speak for myself, I might be, but I insist to everybody that if there's a change in status, that you reevaluate the status. It doesn't have to be only the physician, it could be anybody in the group. But I think the new policy will be, the new form is different. In the current form, it says, do you want to go to the hospital or not? In the new form, it doesn't exist. And so we've been talking about putting a stamp for the long-term care facilities to make that clear. Yeah, I know, I've put with this. But you're right, there's room for improvement, but I think whatever we come up with, we're going to have a rollout communication strategy. I mean, the pamphlets, I want to steal some, because having things that you can give people to read and to do things, I think it's an ongoing discussion. And unfortunately, in long-term care, it is towards the end of people's lives. And I know we try to identify who's dying now, who's going to die in 6 months or 3 months. But the average length of stay is 2 years. The moment you walk into these buildings, you're likely dying. When I came in 2007, there were 40 patients on my floor. 3 of them are still alive. The other 37 have probably died, beds have turned over multiple times. But that's the reality of long-term care. And so this is when people, the moment they come in, I am talking end-of-life palliation versus doing things to prolong their life. And it's rare that in those moments that I'll be able to change that status. When they're closer to death and things are getting worse, it has to be an in-the-moment discussion. And I do believe at that point the physician has to be involved, because they're looking for that type of a guidance. We have to come up with a strategy that works everywhere. Look, there's manpower, there's everything. It's a complicated.
But the conversation starts right from the beginning in home care, when the social worker applies for long-term care, stating to the family, to the future resident that, this is the care you'll receive. Among the care, they could provide palliative care, and it'll be your last place where you receive care. So the conversation is not just at the end of life and when we deal with terminal care, but it should be done right when we apply for long-term care. So it's many conversations in the illness trajectory that we have to have. So we're very focused on who's going to be palliative, who should get the terminal care, but the conversation should begin right from, ideally, at the diagnostic of the chronic disease. The document, the way forward from the Canadian Association really promotes an approach that right from the diagnostic discussion about palliative care should begin. So to help the patient to prepare themselves to the next few years of contact. So many conversations.
Just to emphasize, I so appreciated this question because I think this is exactly what I found with the pamphlets. Is there might be an expectation for a physician to have a certain part of a conversation or to have a hand in when a decision is being made. And so then everyone gets scared and doesn't even know what their role is anymore in having this conversation. To the extent that they don't even feel comfortable handing a pamphlet that a family member can pick up on their own. So I think it's important when a change like this happens for a team to sit down with the physician and say, what is how are we going to do this? I think that's what you're saying. What is our role in this? Because these are ongoing conversations. And when someone's crying at night and a PAB comes in and expresses that they're scared and they think, you know, they're not sure how long they're going to live anymore, that is right now. You know, what is it you're worried about and what would you want to have happen? And is there somebody that you want around, you know, should things take a turn for their worse? And, you know, has anyone spoken to you lately about what's going on with their condition? That's on all of us.
Thank you. I just missed the beginning. This new policy and new law is coming soon.
It's coming soon. We're looking to pilot it in 3 sites, on Sinai, Maimonides, and 1 site in the hospital. The complication is the organization of this piloting thing, which is the complication of lots of things. And we need to get resources together to be able to do something, but that's where we're at. But 2019, yeah, 100%. Yeah, thank you.
Yes.
Thank you so much. We have participants in the webinar that will want to leave, so I want to thank all the panelists. If you want to stay around for questions, you're welcome to. Very complex issue. We've learned a lot. Thank you so much.
Thank you.